Pseudoexfoliation glaucoma is something that we see all the time. It is the most common form of secondary glaucoma, is of the open angle type, of course. It's been reported in every population that's ever been studied, and overall accounts for about 25% of all open angle glaucoma cases. As you know, it's characterized by the white, grayish, granular material that we see on the lens capsule. As you can see in this image, hopefully, there's usually a central disc of this material on the lens capsule and a ring without the material where the iris rubs it off. And then in the peripheral part of the lens, once again, the material is on the lens capsule. No one knows completely in detail what the composition of this material is, but it contains many components of basement membranes. And a great deal has been learned over the last decade or so relating to the etiology of this disease as the genetics have started to become understood. A specific mutation, or a group of mutations of the lysyl oxidase-like 1 protein has been associated with this disease, and the protein product of that gene is present in pseudoexfoliation material. Individuals homozygous for the highest risk LOXL1 allele have over 100 times increased risk of developing the disease. It's also known that the protein produced by this gene is essential in the production of connective tissue, as it catalyzes the first step in the process of collagen and elastin cross-linking. Now, although we see pseudoexfoliation in many patients, not everyone that has pseudoexfoliation material on the lens capsule develops glaucoma. And in fact, many people in the normal population also have risk alleles in the LOXL1 gene that are associated with pseudoexfoliation risk, but not all of them have glaucoma. In fact, it's been estimated that about 15% of those patients who have pseudoexfoliation of the lens examined in a cross-sectional way. So those, if you take all comers and see who has pseudoexfoliation, only 15% have elevated intraocular pressure, but over time, if you follow them for 15 years, then about half, an additional half will develop intraocular pressure elevation. So it's clearly a risk factor, but the finding of a normal phenotype in some individuals that have genetic risk suggests there's a multi-factor etiology with possible environmental factors contributing to the disease. So we have yet a lot to learn about its etiology. Now, there are systemic diseases associated with pseudoexfoliation, and the underlying common theme is dysfunction of connective tissue metabolism. Pseudoexfoliation material has been detected throughout the body in tissues of affected patients, including the heart, the brain, the lungs, the skin, and various diseases, including atrial fibrillation, pelvic organ prolapse, inguinal hernia, and chronic obstructive pulmonary disease have been associated with pseudoexfoliation. Now, why does the intraocular pressure rise? Of course, deposition of the pseudoexfoliation material that's been rubbed off of the lens by the iris is a primary cause of an increase in outflow resistance. Also, there appears to be dysfunction of trabecular endothelial cells and degenerative alterations in the juxtacanalicular connective tissue and Schlemm's canal that can also increase outflow resistance. But it is a disease of increased outflow resistance through these mechanisms. Other structures in the anterior segment are often also coated with the pseudoexfoliation material. Prior to pupillary dilation, you can generally see flakes of material along the pupillary margin, and also there's loss of the pigment and pupillary rough of the pupil. It's also common to see poor dilation of the pupil, pharmacologic dilation, which can be an issue in cataract surgery in these patients. Other structures in the anterior segment are often coated with the material. In this angle image, for example, you can see Schwalbe's line covered with this somewhat pigmented material in addition to the accumulation within the trabecular meshwork. And after dilation, one can often see it on the ciliary body in patients where there's a peripheral iridectomy, and it can also be seen sometimes on adherent to vitreous strands in the anterior vitreous. Another common feature of pseudoexfoliation is weakness or even absence of lens zonules, with lens subluxation in the most severe cases, but with phacodenesis being something that needs to be considered. So before you're doing cataract surgery in a pseudoexfoliation patient, do this kind of a test and look for phacodenesis. It can help you prepare for surgery. Now, what are the issues in terms of management of glaucoma and ocular hypertension in patients with pseudoexfoliation? It's important to understand that this is a disease, when intraocular pressure rises, that is characterized by volatility of the IOP. There's greater fluctuation and greater risk of progression to glaucoma damage, a twofold risk in comparison to to ocular hypertension due to primary ocular hypertension in the absence of pseudoexfoliation. A thinner lamina cribrosa has been postulated to contribute to greater sensitivity to IOP-related damage of the optic nerve in pseudoexfoliation patients. Once glaucoma has developed, the rate of progression has been shown to be higher in patients with pseudoexfoliation compared to primary open-angle glaucoma. Now, with regard to treatment, the approach is similar to other types of open-angle glaucoma, with medical therapy not being specifically tailored to pseudoexfoliation, but intraocular pressure is often more difficult to control, and initial therapy with a prostaglandin analog certainly is our common approach, but it's less likely to, on its own, control intraocular pressure, and more patients end up on multiple medications. The differences in management of pseudoexfoliation come in with consideration to the fact that the efficacy of laser trabeculoplasty can be higher in patients with pseudoexfoliation, and the understanding that IOP volatility is greater with this risk of more rapid progression. Related to this volatility of IOP, it is really important to make sure that the frequency of follow-up examinations is such that important rises or fluctuations in IOP with associated progression will be detected in a timely manner. We need to check the pressure, perform visual field and optic nerve macular imaging more frequently in order to avoid missing things. Now, with regard to laser trabeculoplasty, every form of laser trabeculoplasty so far studied has demonstrated better results in pseudoexfoliation than in primary open-angle glaucoma. An initial laser trabeculoplasty procedure that's been around since the 1960s, argon laser trabeculoplasty, has demonstrated about a 40 compared to about 20% reduction in intraocular pressure in pseudoexfoliation compared to primary open-angle glaucoma patients at 1-year follow-up. Studies looking at selective laser trabeculoplasty in pseudoexfoliation show similar results compared to ALT, with more effective 1-year follow-up intraocular pressure control in pseudoexfoliation compared to primary open-angle glaucoma patients. Although there have been no specific studies reported so far of micropulse laser trabeculoplasty in pseudoexfoliation, again, the results appear to be similar to the other forms of trabeculoplasty, and I would presume that it's more effective in this condition. It's also important when performing the procedure to consider that short-term intraocular pressure spikes may be more likely to occur after laser trabeculoplasty in pseudoexfoliation patients. I usually start with lower power settings. The pigmentation of the material can often lead to greater uptake of the laser, and the endpoint of creating small bubbles can be achieved usually with lower power settings. One might consider also doing a partial rather than a full 360-degree treatment to avoid the risk of a pressure spike, and patients need to be monitored appropriately for the first couple of days. Finally, it's important to consider issues of pseudoexfoliation when considering surgery in these patients. The effect of pseudoexfoliation on anterior segment structures does have important implications in this setting. First, there's a reduced efficacy of pharmacologic dilation. Be prepared to deal with a smaller pupil in these cases. In addition, zonular weakness leads to a higher risk of lens-related complications, and this in vitro model demonstrates the effect of weak zonules on the lens capsule when doing irrigation and aspiration. So you can see the release of the zonules and the central movement of the equator of the lens capsule. You've got to watch out from the anterior view for this kind of a sign when you're doing surgery in these patients, and be very careful when stripping cortex to notice this before there's more significant loss of zonules, and to deal with that accordingly. So in summary, recognition of the presence of pseudoexfoliation is important to identify ocular hypertensive and glaucomatous patients. Realize there's a higher risk of rapid glaucoma progression and visual field loss in these patients. The treatment algorithm is similar to primary open-angle glaucoma, with considering the fact that there's more favorable results with laser trabeculoplasty, but the need to follow patients more closely because of the volatility of IOP. Consider the implications of the disease in performing anterior segment surgery as well. Keep in mind as well that it's a systemic disease of extracellular matrix dysfunction with known genetic underpinnings. And we look forward to developing a greater understanding of the genetics and of the disease that may lead to more targeted interventions specific for pseudoexfoliation. Thank you.
Thank you.